I'm Jacob Lang. Welcome to another special episode of the Mod Pod. I'd like to welcome you back for the second installment of 2026, where we aim to help advance optometric knowledge and elevate our practices and our patient care. So thank you all for joining. I hope your year is off to a good start. I know spring is in the air and spring is springing, as they say. So everyone's got this kind of new ambition and new life, and everything's going good and turning green, at least up here in the Great White North. So I'm honored, as always, to be joined by a couple close friends and colleagues here. We're going to talk about, something I will never experience, presbyopia, right? Forever young over here with the hairline to prove it. So we're going to talk about presbyopia today. No, honestly, something I am in the middle of, and is obviously a priority, much more a priority to me than it was 10 years ago. And for anyone that's not, you just wait, as the patients like to tell us. So my guests that I'm honored to be joined by, Dr. Jackie Garlich and Dr. Mark Dunbar. I'm going to let you guys introduce yourselves, as you can do a way better job than I can.
Hi, yeah, I'm Jackie Garlick. I have a private practice in Boston that sees a lot of primary care patients, but I have a dry eye specialty clinic as well. So I certainly see a lot of presbyopic patients, and yeah, looking forward to the discussion.
So I practice at the Bascom Palmer Eye Institute in Miami, Florida, where I've made a career of this for well over 30 years. I also do comprehensive eye care, primary eye care. I'm known as more of a retina guy, but that's how I started my career. But it's really kind of comprehensive: diabetes, cataracts, presbyopia, deciding higher ads, progressives. I even do a little bit of contact lenses. So I know we're going to get into that discussion, which I'm a novice at, but I'll look forward to having a discussion and hearing what your thoughts are.
Nah, your novice is another man's pro. So let's get into it. Let's talk about presbyopia, right? This inevitable change that's going to happen to our eyes. We won't spend a lot of time talking about this, right? But somewhere between 40 and 50, your arms are going to get a little longer. You're not going to be able to focus as well as you used to. And we now have this new kind of space in optometry focused around pharmaceutical options for treating this. We have drops that help treat presbyopia. And how do they work, Jackie? How do you explain that? What's their mechanism of action? We'll classify all of them kind of together right
Yeah, I
now.
usually, when I'm talking about this with a patient, I just make it very, simple. I just say this works by really constricting your pupil and increasing your depth of focus. This, is how this is working to help you see up close. I don't, go into too much of the details of that, but I think that usually is enough from a patient perspective.
I don't make it too complicated, exactly as Jackie described it.
Yeah. So really, we have miotics right now, and so when we're talking about pharmaceuticals for presbyopia, we're talking about meiosis. Yeah, I always kind of describe it as my dilated patient is kind of staring at me with their big pupils, like this does the opposite, right? We dilate your eyes to check your health, and it makes your vision worse, makes you sensitive to light. We're going to, this medications work in the opposite way. They make your pupils small, and that helps boost the up close vision. So I always use that analogy because that's something I think most people have experienced, much more a dilation than meiosis. So something to think about, and gives us kind of a reference point to discuss about. So this kind of whole space started recently, right? 2021, Vuity was launched. And then the second drop, Closey, was launched in 2023, both pilocarpine based drops. Explain your experience with those, Mark, and kind of what you've seen and kind of that evolution in the early 20s with our first couple of medications in this presbyopic space.
So I, grew up with pilocarpine, right? I mean, obviously we learned about it in our pharmacology classes. We didn't have the prostaglandins. We, of course, had timolol. We didn't have some of the glaucoma drugs that we have today. So pilocarpine was a pretty usual medication that we used. And so, we didn't give it much thought. Obviously, we were all taught the risks of retinal detachments and some of the issues related to pilocarpine. But, quite honestly, I don't think I really ever saw it in clinical practice, mainly because these were elderly patients. When they were on it for life. It was a 4 times a day drop. And so these were really, significant meiosis, you couldn't dilate them worth a darn. And so I'm not sure we ever really got great views of the peripheral retina. But that was our experience, and then, of course, it fell off the radar for a good 20 years, 25 years until Allergan, and among a number of companies recognized the potential of using this drug to treat presbyopia. So, it came to the market, I think, to some degree with a lot of negativity because it was pilocarpine. And, I didn't really buy into the whole issues of retinal detachments, retinal tears, because quite honestly, we didn't see it. It was a different population of patients. So, as you all know, shortly after the commercial release, we began seeing some of these peripheral retinal complications, retinal tears. I think there was 38 to 40 or 42 retinal detachments, VMTs. These were all side effects that really didn't show up in the clinical trials. And so I think it put people on alert. They stopped prescribing it, essentially, I think, buried the drug. So, along comes Closey, which is 0.4%. I will give them a lot of credit regarding, making everybody aware. We created a retinal ad board to really talk about some of the potential side effects. Are we going to see it with a lower concentration? So,
Right. No, I think you hit on some valid points there. We got worried a little bit. We kind of came back, and then we kind of moved forward again. And I think some of that was due to just our lack of understanding, our lack of perception. I think you had some great points there. Most of the listeners here probably have never prescribed pilocarpine for glaucoma. And so when we were talking about this disease state, I was saying, like, yeah, we should use this like at a much higher concentration, like what, 2, 3, 4% pilocarpine you were prescribing, and then like 4 times a day with that as well. So that's a lot of pilocarpine for these patients. If we think about it relatively to what we're talking about in, with Closey, kind of the most common used pilocarpine derivative at 0.4%. So it seems like kind of a very different almost world if we're thinking about it in that.
well, correct. I mean, you think of the population of patients with glaucoma, typically elderly. It was a 4 times a day, and we never really saw a rebound effect of the pupillary meiosis. So, as we know, pilocarpine causes contraction of the ciliary muscle. You get forward displacement of the vitreous, obviously the miotic effect. So, in a patient population that's already had PVD and they're using it 4 times a day, there's really never a recovery phase in those patients. Meanwhile, you look at a presbyopic population where maybe you're mid 40s to 50s and 60s and you're using it maybe once to twice a day. And clearly you've got, the rebound effect where the drug wears off, you start to get, normal state of the pupil, vitreous comes back. And, you think conceptually, if that's happening every day, a couple times a day in certain patients who are at risk, you can see the potential of vitreomacular traction, retinal tears, retinal detachments. And indeed, if you're going to prescribe it on enough patients, the law of averages is, and as we saw, you're going to get patients with retinal detachments, retinal tears, VMTs, and so on. And so, exactly right.
One thing I'll say about that is the people was so I think it's hard to be first to the market and start a new category in terms of a presbyopia drop, but the prescribers of Vuity were not all eye doctors, is what we came to see. And so, I think some of these side effects and these, negative consequence of Vuity could have been avoided had an eye care provider actually been the one prescribing that. So you're having, dermatologists and primary care physicians prescribe this drop without doing a retinal exam. And we know the retinal risk. So, we're not prescribing for patients that have retinal holes or maybe lattice. We're not going to prescribe for that. But a primary care doctor does not do that. So one thing I'll commend Closey for doing is for Orisys for doing is really regulating who actually can prescribe that drop. They're being very mindful and respectful in who's doing that prescribing to really try to be in front of that and avoid any negative consequence. And so in addition to being a 0.4% and a preservative-free option, it's also really well regulated on who's actually what NPIs are allowed to prescribe that. So I think that's why we haven't seen some of these side effects that we saw with Vuity.
Well, and the other side, you're probably going to, maybe that's your next question, Jacob, is really, does lower concentration make a difference? And as you guys are well aware, Bascom Palmer apparently has one of the only OCTs that can measure ciliary muscle thickness. And so, um, Orsis went to Bascom Palmer, listen, can we check our theory out? And what they found was with 0.4% pilocarpine with the Closey drop, it really mimicked the same ciliary muscle effect that you get with balanced salt solution. So we're really not seeing the same effect as you would with a higher concentration of pilocarpine. So certainly it is a selective agent where you're not getting the same type of posterior segment effect that you are with a higher concentration of pilocarpine. And indeed, when you go to the FDA's adverse event site, there have not been any reported retinal tears, retinal detachments, unlike what we saw with Vuity. So I think it really puts to rest some of the worries and concerns that we have that indeed, this drug, pilocarpine in particular, is concentration dependent in terms of developing some of these same posterior segment, concerns. Whereas I think you still get the same miotic effect and the same efficacy.
That was a great point, and a great study came out of a great institution, by the way. So really interesting to see, like, actually looking at what's going on in the ciliary muscle and seeing, we're trying to get meiosis and pupil size reduction, but what else are we doing? And so it's interesting to see that we're starting to think about clinical trials, maybe even in a different way, and how we're looking at what these medications are doing. Like I said at the beginning, these are all miotics, and so they all are making the pupil smaller. And I think it's a little sometimes naive to say, like, this one does it this way and this one does it that way. Yes, there's definitely a different mechanism of action, and we're going to get into that next. But yes, we have these different mechanisms of actions and different drugs that do different things. But in the end of the day, they kind of all do the same thing. So it is somewhat naive to think that, this one's going to make the pupil smaller, but not do anything to the back of the eye and stuff like that. So it is kind of cool to see companies putting their money where their mouth is, looking at ciliary muscle changes. But as providers and doctors, I think we have to look at this as a class of medication, right? A class of miotics. And so we should be doctors and know the understanding of the mechanism of action of all miotics, and kind of be careful in our patients, to Jackie's point, to protect our patients and think about who's a good candidate and who's not a good candidate. What has been your thoughts on Viz and Uvezi? And then we'll just ask Mark the same.
This whole category, I think, has exploded. I mean, we now have 4 options for presbyopia drops to choose from. And the reality is this is still a super new category. And all of these drops are really still relatively new. I think what we will see in the years to come is that maybe we have a better idea of which patient does better with which drop. The lighter iris and this size pupil at baseline might respond better to X drop versus Y. And I don't know those answers yet either, but I'm pretty sure we'll end up figuring out a better algorithm on who to treat and when. Viz, what we're seeing is, there's probably the thing that was most surprising to me was the hyperemia when that drop was put in. So that wasn't a noticeable thing. In reality, some patients are not that bothered. That does tend to subside the more that you use the drop. And certainly I was having some patients use a little Lumify right after that, but just to try to help with some of that hyperemia. But if that drop does certainly last a long time, you can get 10 hours of up close vision with Viz, which is longer than what we were seeing with the pilocarpine drop. So I think some of this, a lot of my patients will want to use this situationally. I have very few who use it every single day as their, way to read up close. I think these are just more tools in the toolbox. And sometimes that 10-hour duration doesn't matter as much for my patient who's going out to dinner and just wants it for their evening out. May not be 10 hours unless it's a wild night, but they might not need that. So I think it is, a lot of this is conversation with your patient to see what are we looking to do with this? What are your expectations? What are you wanting for this? And Uvezi is so new, so we're just really starting to play with that. So I, don't have much feedback to even report on that, as that was really only commercially launched, last month actually. So all new, but great, nice to have options for patients.
I agree exactly with everything Jackie said. I think that, tolerability, the redness is an issue. It doesn't seem to be a huge barrier. So, as of probably 3 or 4 months ago, when I was making a decision, I think, Closey's more tolerable, but shorter duration of action. And I would think, well, for some people that may be a plus. Maybe you don't want it to last 10 hours. Other people, maybe they do want that duration of that longer duration of action. So that was always the kind of the the issue that I would wrestle with clinically on which one to prescribe. But obviously you've all seen the direct to consumer, and I'm a big believer in direct to consumer, and marketing is everything. And so now I've got people coming in specifically requesting Viz. And if they're requesting it, we talk about it, well, it may cause a little bit of redness, but boy, you're going to get a great duration of action. Cost has not been a barrier for most of these patients. I think it's very affordable for that patient who, from a disposable income perspective, they don't bat an eye. So it's, as Jackie said, you educate them what to expect. Don't use it just once or twice, but more and more and more are coming in requesting this drug. And so, you're not going to say, well, I would recommend the other one, right? I don't think that's a winner for anybody because that's what they came in for. Let's give them what they want. I let them know that there's other options available that, again, Closey doesn't maybe last as long, but I think it's a little more tolerable, more comfortable medication. But let's try this. If you want to try the other one, please let me know.
I think, that's kind of a call to action here too, is that patients are going to want this. And we saw that with Vuity, that when the direct to consumer stuff ramps up, these patients are going to be in offices asking for this. And hopefully they're in eye care's offices asking this and having conversations with their provider, and not in their primary care doctor's office or their OBGYN's office asking for a prescription for this, where they need to be where eye care takes place. And so my call to action for optometry would be to embrace the conversations with your patient, and embrace the conversations around using this for patients. And to Jackie's point, like, what do you want to do? What do you want to get out of this drop? How maybe these drops can help you, but let me help you help yourself. And so to be a resource for our patients, and help them with that. Jackie?
Honestly, half of treating presbyopia is expectation setting. Right? Like whether we're talking about a multifocal or drops, it's really what does the patient want, but also what's a realistic want out of those drops. And so knowing that and setting those expectations, I think is critical.
Yeah, and it's not like putting on a pair of over-the-counter readers where boom, all of a sudden you get this dramatic magnification effect that, it's not going to be that way. It's going to be, you'll be able to see and what you need to see in terms of a computer and reading a newspaper, et cetera. So again, I agree with you 100%. It's making sure it's not like when you put on your over-the-counters and all of a sudden you get this dramatic magnification effect.
That's a really good point, and I didn't realize that actually. Like, I not that I didn't think it was mag, but when I was talking with someone else about this, I was like, oh yeah, it's not mag. It's just clearer. The size is the same of the near print. It's just a sharper image. It's not mag. So some of that is expectation setting for the patient too. Good point.
Kind of talk about like these drops having, some have milder facts and you have to use them twice a day, like Closey. Viz, we talked about having kind of maybe the longest duration of effect, but maybe some more side effects like headache, redness, dimming, those sort of things. So we have a colleague that does these drops, and he uses this for this and that for that. So he might, be using, oh, this is a Closey day or this is a Viz day. So it's going to be interesting to see where this evolves and where we think about this. But tell me more about like patient selection. What drops do you recommend and when? And have you noticed any trends in patients that are trying to have, achieve these goals? Like we said, Jackie, the menu, go out for dinner. Is that a better Closey patient? Is that better Uvezi patient? And when do you reach for what? And where are we going with this now? Like you said, that we have all these options.
Yeah, I think some of it is I really need to start myself experimenting more with Uvezi, as I have the least experience with that one. But up until that was, approved, I would talk mostly the two main deciding factors were really the duration of action and the side effect profile. And if a patient was turned off by the ideas of their eyes red. I mean, right, they're using this drop for a cosmetic reason. Like they don't want readers. So if we give them a drop and then their eyes are red, like, ugh, like that's also not what we want. So then if they're kind of turned off by that or the idea of having to use drop a Lumify to like clear that up, then sometimes I'm reaching, then I might reach more for Closey. That would be probably my other reach. Or if they're, so a lot of times those are the two deciding factors. And certainly there's, refractive parameters that I'm thinking about for a patient. Your what seem to be like easy cases are your post-refractive patients, or your patients with low hyperopia or low myopia that just, need some help up close. But sometimes in reality, that doesn't work. And I don't have a good explanation why that is. Like, I had a perfect, what I thought would be a perfect patient, post LASIK patient, is basically Plano and just needs help reading. She needs like a 175 ad. And I was like, this is a slam dunk. And she was like, nope, I didn't like it. This is what I mean about like, oh, okay. What was it about her baseline characteristics that made her not enjoy that drop? Or should she be doing a different drop? So I think I need to do my own personal in-house studies to really kind of pull that information. I don't know if you're seeing something similar, Mark, or you think someone's a slam dunk and then they don't work as well. And then conversely, another patient I had, I was like, I don't know if this is going to work for you. You're like a diopter and a half of hyperopia with like 150 sil. Let's try it. And he's like, it's perfect. I love it. I was like, okay, great. Like, I feel like, I don't know. We're going to see how this all kind of shakes out. I don't know. Are you finding that, Mark? Or
Well, the hyperope like that, I probably wouldn't have even considered, and maybe I need to. I'm pretty much, by the book, the 45 to 60. If they're over a +1 or a 150, I probably wouldn't consider it. But, I think, again, the whole marketing idea of, if you want to differentiate yourself in your practice, it's important to have this on your radar and let patients know that there is a drop that exists. That's, you don't have to rely on an over the counter. And I think, despite maybe some of the negativity around the drops, it is there. This is a class of drops that will work for patients. Obviously, managing expectations, as you talked about, is critical. And I think by not mentioning it, I think it they're going to hear it, through friends or direct to consumer. And then the question is, well, why didn't this get brought up, right? And so, but I go through the same, question marks. What is the best patient, and which one should I prescribe? And I wasn't aware that Uvezi is commercially available yet. I know it was FDA approved, but and again, I haven't prescribed it at all. I believe that all these drops are going to work probably equally well. I'm not sure that there's going to be a front runner on, efficacy. It's just managing, expectations and tolerability and duration of action, and that's the hard one. I just had a patient. Interestingly, I thought about this today. A patient who had multifocal lenses and was complaining at glare at night, and so the question was, gosh, would I recommend? The problem is you get so much meiosis that may not be quite the drop, and so then I was looking at bromonidine as really an option, but it crossed my mind: should I talk about one of these presbyopia drops to kind of get them, because I have no doubt that would reduce any glare that this patient with multifocal lenses have, but maybe too much.
well, that's a whole nother category of like being able to, can we combine this with a multifocal to give them a little more boost that maybe the multifocal is not getting, or doing a modified monovision with a, multifocal in one and distance. Like the combinations are like, there's so many different options that we could do. We just need some more time to figure that out. What's going to work best.
So, in with regards to contacts, let's talk about contacts and presbyopia, Jackie. What's your like? Do you do monovision much anymore? Are you a believer in monovision, or have those days come and gone? Is that our predecessors' way of correcting presbyopia?
I'm more a multifocal gal. I do like to keep people binocular whenever possible. I certainly talk about monovision and have it as another option if for some reason I just cannot get what I need in a multifocal. I'll say there is also this monovision option, but I do not lean to that. It's honestly rare that I'm doing it. Sometimes I will do more so if I'm heading down the monovision, right? I'll do a route. I'll do a modified monovision where I've got maybe just a distance only in one eye and then a multifocal in the other. So sometimes I'll play around with that, but I am more of a multifocal gal myself.
I think we've all embraced the multifocality and presbyopia options in contact lenses. Have you guys started to and not or these two things? Are you using miotics with contact lenses? Are you using miotics with regular contact lenses, or multifocal contact lenses, or even specialty contact lenses where we might be trying to reduce higher order aberrations, and we know a myotic pupil is going to help reduce some of those higher order aberrations. Where are you at with embracing a multi-layered level of correction for both presbyopia and these kind of off-label, outside the box thinking thoughts stuff that we're thinking about?
Yeah, I've honestly I've messed around with all of that. So, really,
Yes, and yes, and
yeah,
yes.
yes and yes. I mean, it is wonderful to have these nuances and really kind of like think like, oh, maybe if I constrict this pupil a little bit, I'll get a little like it is sort of tweaking what you are already use. And so I've done both where I've tried a myotic with a multifocal. I've yet to be really successful in that, to be honest with you. I will sometimes then say, let me try it in just a distance only, and then do the myotic on top of that, and that has worked. But I think there's such huge applications for the higher order aberrations for our corneas that are having some trouble to be able to shrink that pupil down and get a little better vision for those patients. So yeah, yes and yes and yes to all of that.
Yeah, I don't fit enough contact lenses to, I think about it, and I'll tell you, I have a lot of, not that I fit them, they just come in, a lot of the monovision patients, and interestingly, our cataract surgeons still do a lot of monovision. So, I see it. Obviously, not everybody's happy, especially after, cataract surgery, but in the contact lens space, not so much.
It'd be interesting. To your point, Mark, like I kind of grew up in that early LASIK days when we had a lot more complaints about patients with glare, and we used to prescribe Pilo off-label and Alphagan and these sort of things. Tell them to leave the dome light on in the car. If you might be presbyopic, if you know what a dome light is, I don't know. But yeah, it'll be interesting to see what other visual effects we can have for our patients. And I think it really has to break down to the conversation around the patient's needs and things like that. So I'm going to pose to you both as we wrap up here, like I'm going to pose one more question, then we'll wrap up. You get to pick two. So we've got like surgical options with IOL, we've got pharmaceuticals, we've got glasses, we've got contacts. You can wear or use two things to correct your presbyopia for the rest of your days. What are you picking? And Mark, I'm going to let you go first.
Everything on board. I mean, I think I would, number one, given the choice, choose a multifocal IOL, just because I think it'll do everything. The problem is I don't like the way I look without glasses. So between the bags under my eyes and whatnot, and then if you were an emetrop, I mean, quite honestly, I don't have a burden with over the counter readers. Lose them, break them, have them everywhere. So I'm not personally so desperate that I want to avoid, having some type of optical correction on my face or, in my eye.
Yeah. No, strategically locate the cheaters, and a chance to cut is a chance to cure. I love that.
I think it depends on I mean, I'm kind of with Mark. I have eye bags as well. So I do kind of like the idea of me still wearing glasses. I don't know, but I think I might choose a multifocal IOL. I have dry eye, so I probably won't be throwing a contact lens in myself if that's my choice. So I would say specs or multifocal IOL is
Ooh,
probably
look
what I
at you
would
guys.
choose.
You're all in. I
Yeah.
love it. That's good stuff.
Technology is great because we have so many options and so many things to think about and talk about with our patients. And I just think it's, as boring as presbyopia potentially can sound. I mean, I think these are fun conversations to have, in a population of patients that we deal with. So I really find there's a lot of self gratification being able to make a difference in a patient's life by the recommendations that we provide, and patients coming back, and you get reaffirmation on some of those recommendations. So it's great to be an optometrist.
I don't think I can say it any better than that. So I'll leave it with Mark's comments, and just thank you both for being here and spending some time with me. I really appreciate you and all the things you're doing for optometry. Again, I'm Jacob Lang. Thank you to our audience for listening to this special episode of the Mod Pod. Please stay tuned for another installment. We'll be coming your way soon. Thanks, everyone.